Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with bilateral layers of dead thick skin coating both the ear canal and also the eardrum. Their left ear was the worst one, and for that reason we're commencing on this side. So this is the patient's left ear. They had visited their doctor previously and they were advised that they do have some debris and wax skin in the ear, but it wasn't occluding, and I somewhat agree in that sense. I would say this is partially occluding. You can see the eardrum posterior to the right, but it wasn't creating a complete acoustic seal. As such, they were advised just to use some drops, and it shouldn't really affect them. And if truth be told, many years ago, before I started performing ear care, so I was still an audiologist, I probably would have agreed. But when you have been performing clinical ear care like I have for a number of years now, I can now fully appreciate even how, like for the right ear, for example, you can see the right side after we do this. There was just some dead skin on the eardrum, and you wouldn't have thought that would have impacted the patient's hearing significantly, but it certainly did in this case. And I think you can only really get an appreciation of that when you perform the procedures yourself and obtain the patient reactions. So this dead skin, it's really thick and callous, it's quite dense and dry, it's really adhered, and immediately I had to put some drops in because it was solid, and for that reason it was difficult to get a suction grip. So when there's dead skin in the ear, I prefer to use sodium bicarbonate drops as opposed to olive oil. Olive oil is normally what I recommend patients to soften earwax, or what I use during my procedures. But when you've got dead skin, olive oil doesn't really do much. It's almost like it gets repelled. With the sodium bicarbonate drops, because it's water-based, which is, again, I don't like using water-based solutions because they are slightly alkaline and it raises the pH, and it can cause maceration and softness of the skin, which can then break that down. But in this case, that's the whole concept. Because this is dead skin as opposed to earwax, sodium bicarbonate drops works much better in breaking down the skin. So skin is actually hydrophilic, it's water-liking, so it absorbs the sodium bicarbonate solution, which is water-based, and it overhydrates, and then it creates the skin cells to burst. Therefore, it breaks down, it doesn't dissolve. When you say dissolve, I quite literal, so I take the meaning of dissolves, disappear, but what it does, it breaks down the skin a bit better than olive oil, and it then makes it easier to remove. So what I've just done, I've manoeuvred this skin off the anterior canal wall for the front part of the ear canal, and that's then allowed me to insert the crocodile forceps. Initially, there wasn't enough gap, so if I continued using the forceps, you may have seen I redrew from the forceps earlier. If I continued the first time with the forceps, the top jaw would have grazed the front part of the ear canal and it wouldn't have been comfortable, so I had to create more of a gap, which I managed to do, and then I extracted the skin. So all this skin now, it's like shards of really dry skin. It's really sharp around the edges. When I was holding it afterwards, it was quite uncomfortable actually. It was almost like sandpaper, and the patient themselves had held it so they can get a feel of it. So we still got this dead skin on the eardrum. So the left ear now looks like the right. So you will see the right ear afterwards. It's almost a carbon copy now, and we're faced with the task of removing this. And this skin now, it's right on the eardrum. You can see it. I'm working on the posterior quadrants of the back part of the eardrum, and you can see the blue tinge behind the eardrum, but this skin is really adhered. It doesn't want to come away. So I think I'm just going to go to the roof. So this section of the ear canal and eardrum is called the posterior superior region, so the back and north region. It is also quite a sensitive region. I'm just trying to get a suction grip, but the skin, it was coming away, but it was then just bouncing back. It was flexing back onto the canal wall. Therefore, I've gone back to the eardrum to see if I can remove this. And it's really crystallized. You can see just how crusted it is. I'm just going to have another attempt, but I think, if memory serves me correct, I'm going to just put some more sodium bicarbonate drops in a moment. Now, I've called this ASMR, dead skin removal from the ear. The reason being is there's a point and around 14 minutes and 10 seconds where I actually experienced a bit of ASMR myself when I was watching it back. You may have seen that I went back in with the forceps, but I wasn't able to enter the forceps, extend the forceps any further into the ear canal, because if I did, the bottom jaw would graze the back part of the ear canal. So although there was a bit of dead skin protruding off the eardrum, I thought if I can grip it with the forceps, I could extract it. There just wasn't enough physical space, and the only way I could grab onto that small piece of skin was by positioning the forceps in such a way where the bottom jaw will graze the back part of the ear canal. So I just again withdrew the forceps, put some more drops in, and that seems to have done the trick. The skin is now peeling away. So the bottom hemisphere of the eardrum is fully visible, and now the north hemisphere is visible. There is just a bit of dead skin anterior in the anterior recess. That's the hardest part of the ear to gain access to. If I was using a microscope or head loops or even the wax scope, for example, because the lenses of the wax scope, microscope or head loops is external, it doesn't go into the ear like an endoscope, hence the name endoscope. The lens is inside the ear, the camera, the telescope if you like, is in the ear. You would really struggle to see this part, but with an endoscope you can. And you can see I managed to remove some dead skin there. There is going to be a little bit still left, but I'm not concerned by that. I'm hoping that's going to now just naturally migrate. With these procedures, you've just got to weigh up the risk-benefit, and I did explain that to the patient previously. I said there might just be a bit of dead skin here and there, but we don't want to be silly where in an attempt to remove every little last speck, and this is not really going to affect the patient, we could do some injury and trauma to the ear canal and eardrum, and the patient agreed. So I explained to the patient, as soon as I felt we're hovering over that threshold of the risk-benefit, that I'm going to stop. You can see that I am actually on the eardrum here, just sliding against the ear canal. It's just not going to come away, so we just left that. It's not a problem. You can see 99% of the eardrum. And I'm just now going back to the entrance. Whenever I perform a procedure, I like to get to the business end straight away, and that, unless removing this will help me remove the dead skin from the eardrum. And in this ear, it didn't, but in the right ear, you will see that when I went straight for the eardrum and the more medial dead skin, it wasn't budging, so I then had to come back to the entrance. Removing the skin at the entrance then facilitated the removal of dead skin further in. In the left side, it was a bit different. The skin was completely detached from the more medial skin. So I decided just to get all the skin off the eardrum first and then come back out and just finish off the removal of all this dead skin more laterally, so near the entrance. Immediately the patient noticed a massive improvement, especially with their own voice. They found their own voice to be a lot crisper and sharper. So by no means were they hard of hearing with that. They just noticed that the hearing wasn't as clear and sharp as it previously was. And it's just something that the patient came across me on, I think it was on TikTok actually, or it may have been Facebook. Maybe it was both. And they saw a similar procedure, and so they travelled down to the clinic to visit myself. Where did they travel from? I think they travelled from Surrey, so it's a good 2.5 hour drive each way. Yeah, and they found that their own voice was a lot sharper, more treble. So that's the left ear complete now. We're going to go to the right ear, and you can see all that dead skin around the periphery. I immediately put some sodium bicarbonate drops in just to soften this. I think I start off posteriorly here. I thought there's a good region. If I start to peel this away, it'll come off the drum, but again, it was very callous, very thickened, so it's very difficult to remove. And remember, we're working on the osseous region here, the bony part. The bony part of the ear canal is extremely sensitive, and that's because lining the bony part of the ear canal is a very, very thin layer of skin. less than 0.1 millimeters in thickness, and that skin layer, we call that stratified squamous epithelial skin. I missed out an important word actually there, so I'll just repeat that again. So the skin that lines the inner 2/3 of the ear canal, the bony part of the ear canal, is called stratified squamous keratinous. That's the word I missed the first time. Epithelial skin. And let me just break that down into fancy, because that's quite a complicated sounding word there. The term stratified is basically translated as a layer. Okay, so layers. So stratified equals layers. Squamous actually just means a flat skin cell, almost like a fish scale. In fact, I think the Latin translation is a fish scale. So there's different types of skin cells you can get, and cells in general. You can get squamous, or flat ones. You can get cuboidal, and you can get columnar, so it's more like a rectangle. So this is the skin that lines the ear canal. It's squamous. It's like a fish scale. They're flat like pancakes. Keratinous just means that this skin contains keratin, the protein keratin, which we also find in our fingernails and hair. And epithelial means the outer layer of skin. You can call that the epidermis. So in terms of the bony part of the ear canal, it only contains the outer layer of skin. So skin generally has 3 layers. You've got the epidermis, so the outermost surface skin. Then you've got the dermis, which is the middle layer where all the hair follicles are located, and all the sebaceous glands and ceremonous glands. And then you've got the subcutaneous layer, which is made up of connective tissue and insulating fat. So the skin that lines the inner 2/3 of the ear canal is just that outermost layer, epithelial layer. And because it's only the outer layer, it's extremely thin, and that's sitting directly on the bone. Well, there is another a medium there called a periosteum, so that helps supply the blood supply. But it's such a thin layer of skin, so if you do come in contact with the bony part of the ear canal, the patient will certainly notice. Sometimes I think I've had comments before where people sometimes probably criticise me for being a bit too cautious, and I'd see that as a positive actually. I just don't want to injure or hurt anyone, so I'd rather be a bit cautious just to remove, or if it takes me a few minutes longer, I'd rather just do that so the patient's comfortable. That for me is the most important part of what I do. I just want to I don't want to inflict any trauma or pain to the patient. So again, I've just put some more sodium bicarbonate drops in, really dosing this. So the skin that lines the outer 1/3 of the ear canal, it has the full 3 layers. So you've got that same epithelial layer that I discussed before. Then you've got the dermis, and also you've got the subcutaneous. It's a much thicker layer of skin. It's about 1 millimeter in thickness, so 10 times thicker than the skin that lines the ear canal. And that sits on cartilage. So cartilage, unlike bone, is flexible, whereas bone is rigid. So you've got it's a lot softer, a lot more flexible, less sensitive, the outer 1/3 of the ear canal. So if I'm working on the cartilaginous portion, the outer 1/3, sometimes I'm making a bit of contact with the cartilage because the patient is not really going to feel that. It's going to be comfortable for them. Now, this skin from both ears that I'm removing, for the majority of us, this skin would naturally migrate out of the ear by itself. And we call that the epithelial migration of skin. The ear has uniquely evolved whereby as the skin dies and sheds, it then on its own accord naturally migrates, and it does that by moving sideways towards the entrance in a conveyor belt motion. And the ear has evolved in such a way because, unlike the rest of the body, if you've got dead skin on your scalp, for example, or your forehead or your arm, that skin, as it dies and sheds, it just naturally falls off your body to the ground, either through when you're bathing or showering, or when you're putting your clothes on, sometimes when you itch yourself. So there's no risk of dead skin collecting really on other parts of the body, but with the ear, because it's an internal cavity, the skin, if it wasn't able to migrate on it by itself out of the ear, everyone's ears would be full of dead skin. And in fact, unfortunately for some patients, that is the case. Some people, like this patient, they suffer from this buildup of dead skin, where the skin fails to migrate out of the ear on its own accord, and then it can cause problems. So there's a possibility this patient will have to have this performed again in the future. Just a bit of drops. You can see the little bubbly drops there. I didn't think there was any more skin actually, and I think I've just gone past that ASMR portion where I experienced it. So I was just busy talking and didn't notice that. So around 14 minutes and 10. I suspect some of you may not experience ASMR when you're watching it, or some people experience it multiple times during the procedure and at different stages. But just at that particular moment, for around, if you start watching it around 14 minutes and 10, I don't think it was exactly that portion, but it's when I re-entered the ear at that stage, I experienced it. So that layer of skin was actually unexpected. I didn't realise it would. So it was such a thin layer of skin, and it was really transparent. Now there's two little specks here, so again, I pre-warned the patient that I'm not overly concerned. I'm going to hover over. If it come away, fantastic. If not, we're going to leave that there because it's right on the hammer bone, the malleus bone, and that bone is attached to the eardrum on the underneath side. So again, if you touch that, it's going to be uncomfortable. You can see I've just bent the end of the fine tip just to get access into the anterior recess. So I'm really happy with that. Well, I hope you enjoyed that video, guys. Do take care, keep well, speak soon. Bye.